Well, good afternoon. Welcome to UCSD's inaugural Zoom Symposium for Advanced Practice Providers. It's a wonderful pleasure to introduce Rachel Shapiro, a board-certified physician's assistant who specializes in urology here at UCSD. Within her independent practice, she treats a wide range of benign urological conditions. However, her specialty focuses are avoiding dysfunction, neurogenic bladder, urolithiasis, and transition care urology for patients with congenital urologic conditions. Rachel joined UCSD in 2016, and since then has built her own practice as well as supporting several other physicians within our large department. She has also become one of only 2 PAs in the state of California to have obtained her fluoroscopy license after creating a fluoroscopy education program for allied health professionals. She performs a wide range of procedures, including video urodynamics, cystoscopies, prostate biopsies, and percutaneous nerve evaluations for sacral nerve stimulation. Prior to joining UCSD, Rachel was a PA at Mount Sinai Medical Center in New York. She received her master's in health sciences for PAs at Cornell. In New York, she treated primarily urolithiasis and assisted in the operating room, as well as helping with ureteroscopic procedures. Outside of work, Rachel enjoys international travel, cycling, and spending time with her husband and 2 beautiful children. Well, it's a wonderful pleasure to introduce Rachel, and she will be presenting to us the evaluation and management of storage lower urinary tract symptoms, pearls from an OAB practice. Rachel.
Thanks so much, Dr. Monga. I really appreciate the lovely introduction. And thanks everyone for joining us today for the first of this webinar series. We're so excited. Thank you to UCSD for putting on this program. We have a really great lineup over the next 8 weeks for all of you that's going to cover a range of urologic topics that hopefully has something for everyone from the beginner to the seasoned veteran of urology. So a reminder that all of our webinars will be recorded and are going to be available for you to watch afterward on our YouTube channel. We have an APP Zoomposium YouTube channel. We should be able to say the name. And a link is going to be sent out via email afterward. And you can also follow us at UCSD Urology and myself at PA_SD on Twitter for those links. After the talk today, we're going to have some Q&A, and you can see at the bottom or top, depending on your Zoom platform or format, the Q&A button. If you'd like to ask a question, we'll save those questions and answers for the end, but I will be fielding those at the end as well. Okay. So to jump in, so the reason why I didn't just decide to give a talk today just on overactive bladder, and I wanted to broaden it in order to talk about storage lower urinary tract symptoms in general, is because we have guidelines available for overactive bladder, for BPH surgical management, for IC, for neurogenic bladder, but patients don't always fall into a neat little bucket, just like that. And so when a patient comes into your office for urinary frequency or for urgency incontinence, how do you tease out what's really going on with those patients, and where are you going to focus your efforts, and what are your treatment options? And so that's where the talk is going to go today. To make sure I can advance these slides here. There we go. So I have one disclosure. All right, so in talking about lower urinary tract symptoms, we split them in between voiding symptoms and storage symptoms. So our voiding symptoms are the weak stream, taking a long time to urinate, feeling like you need to push to urinate, or feeling like you're not emptying your bladder, and these are classic symptoms of BPH or obstruction. And then we have our storage symptoms, such as frequency of urination, waking up at night, feeling like you have to run to the bathroom because it's so urgent, and incontinence. And today we're going to be focusing on the urgency incontinence. All right, so why is this important? Well, it's a highly prevalent condition. So there were a couple of random population sampling studies out of, let's see, the EPIC study out of Canada and Europe looked at 19,000 individuals and noted that 51% of men and 59% of women reported having at least one storage lower urinary tract symptom. And then the LUTS study, which included the US, the UK, and Sweden, surveyed 30,000 individuals and noted that almost 46% of men and almost 67% of women reported storage lower urinary tract symptoms. And in the LUTS study, they actually administered a questionnaire. And in that questionnaire, they noted that 16 to 27% of men and 33 to 43% of women could be classified as having OAB based on the responses to those questionnaires. And in addition to being highly prevalent, there is a considerable economic impact that's associated. So men with overactive bladder are 1.5 times more likely to be unemployed compared to matched controls. Women are more likely to work part-time. Men and women with OAB are more likely to be retired or to be disabled. And GANS estimated that the total economic burden, including both direct and indirect costs back in 2007, was estimated already to be close to 66 billion, and they predicted that to rise to 83 billion now in 2020. And Durden compared the overall healthcare costs between OAB patients and non-OAB patients and noted a 2.5-fold increase in those healthcare costs for the OAB patient population. So there's a considerable personal impact to the patient as well as global economic burden. And so when a patient comes in with these storage symptoms, we know that they can be related to or can be caused by benign prostate enlargement, idiopathic OAB, bladder pain syndrome or hypersensitivity, pelvic floor dysfunction, genitourinary syndrome of menopause, pelvic organ prolapse. They can be caused by malignancy or prostatitis, neurogenic conditions, diabetes, either because of the neuropathy that's caused by longstanding uncontrolled diabetes or because of the irritative effect of the glucosuria. Medications can cause polydipsia, polyuria, and obstructive sleep apnea. So all of these are potential etiologies for the patient who comes in and tells you that they have some storage symptoms. But our referrals look a little bit more like this. They might be referred for BPH or for prostatitis, to rule out interstitial cystitis, or for a recurrent UTI, which inevitably is not responsive to typical antibiotic treatment, they might say, or with cultures that are negative. So not only are we tasked with teasing out what's really going on with these patients, but also with helping them to move past some potential preconceptions that they may have because of a potential prior label by a diagnostician already. And so where do we begin with our evaluation? Well, we start with taking a good history, as we always do. And you want to assess the storage, the voiding, and the post-micturition symptoms like dribbling individually. Ask them those individual questions. Do you have frequency? Do you strain to urinate? Do you have incontinence? When do you leak? There are many different validated questionnaires that we can use. Among the most common is the International Prostate Symptom Score, the AUA Symptom Score, which has been validated in both men and in women. But there's also the OAB symptom score and many of these others, and these can be used as both initial diagnostic tools as well as to help follow the progress of your patient as you embark on a treatment plan with them. For patients who are wet and they come to you, you can ask them about how many pads per day they use, but just be careful to ask more specific questions. It's not always that straightforward. Patients may start out with very large, thick pads and may be able to graduate to thinner panty liner pads. I have patients who come in who layer toilet paper inside of a pad, inside of a diaper, and so there are some nuances to that. And you want to ask them how wet or soaked their pads or their diapers are to get a sense of not only where they're starting, but how they progress with your treatment. So some other questions that I find particularly helpful. This one, what happens when you try to hold your urine? So the patient who tells me that when they try to hold their urine, they leak, or they have leaked, or they're afraid that they will leak, maybe pushes me more in the direction of detrusor overactivity versus the patient who tells me that when they try to hold their urine, they have pain. In that patient, I might be thinking more about hypersensitivity, pelvic floor dysfunction, bladder pain syndrome. And then there's the patient who tells me that they are just becoming more uncomfortable or the urge just gets stronger. And that may be a patient who has conditioned themselves to urinate earlier than maybe they need to, may benefit from pelvic floor physical therapy or bladder training. And these are not steadfast rules one way or the other. These things can, coexist, but it pushes me sometimes in one direction versus another in terms of what the etiologies might be. I'll get patients who come in and they'll say that they've tried and they failed a certain medication. But don't forget, it's important to ask how long they took the medication and whether they took it regularly. We know that for anticholinergic medications and beta-3 agonists, that they must take it for 6 weeks in order to see a maximal benefit. So if they hadn't taken it for that long, it's not really a true trial of the medication. And we want to know what symptoms bother the patient the most. And one way I might ask this is, if I could fix one thing for you today, what would it be? And, you know, it's our job to assess the entire patient and make sure that we understand all of the different factors that might be contributing to their symptoms and that we treat the whole patient. But if they're bothered by one specific thing, for example, if they're bothered by nocturia, and they have mixed symptoms during the day as well, and I treat them and their mixed symptoms get better, but their nocturia doesn't, then I've done that patient a disservice. So it's important not to lose sight of what's actually really the most bothersome thing with the patient. And then in follow-up, I'll ask them if they're happy with the way things are now, or if they desire additional improvements. Because while I may not be happy with 2 pads per day incontinence, my 80-year-old patient with Parkinson's disease and urgency incontinence might be very happy with that. And in the absence of any concerning etiologies like malignancy or an infection, the storage symptoms that these patients come with are a quality of life issue. And so we want to make sure we're not chasing down additional therapies when patients are content with the symptoms the way they are now. All right, so moving on to the physical exam. As part of my first part of my physical exam, I'll do a simple assessment of frailty of the patient and their functional status via their mobility and their cognition. And this is important to ensure success of your treatment plan. You know, our guidelines for OAB and for BPH surgical management are somewhat agnostic to the fact that this 20-year-old female who has urgency and frequency is going to have a different set of goals and a different ability to tolerate certain therapies than this 80-year-old gentleman who is walker dependent. And so that's just something to keep in mind while you're getting your initial evaluation. Pay attention to obesity. There's good data to show that weight loss is associated with reduction of storage lower urinary tract symptoms. And pay attention to lower extremity edema, because that will have an effect on nocturia. For our neurological exam, so it's important for any patient who is arriving with new lower urinary tract symptoms to do a good lumbosacral neurological exam. So we can assess strength, do a little hip flexion extension, or at the knee, ankle dorsiflexion, plantar flexion, and chronicle the strength on the standard scale. Assess for sensation along the dermatomes. You know, it's simple. Can you feel this? Is it the same on both sides? Assess for reflexes. The patellar reflex will assess for L3 and L4, and the Achilles reflex for L5, S1, and S2. Assess the patient's gait. Is there a shuffling pattern? Are they favoring one side versus the other? If there's a concern about Parkinson's disease, you can assess for bradykinesia by doing the finger tap testing. Look for anal sphincter tone and assess mental status. And the purpose of all of this is, obviously we don't want to miss something. If there's something off on this exam, then that will prompt a referral. But for patients who are already coming in with a neurologic diagnosis, or who already are established with neurology, it's important for you to also establish their baseline and follow it with time, because if you see that their neurologic condition is progressing, that may tell you something more about what's going on with their lower urinary tract, if their lower urinary tract symptoms are also progressing, and may give you a different assessment of their outcomes to different therapies you may recommend. So for the pelvic exam, let's not skimp on our pelvic exams for males and for females. You know, every 20-year-old or 30-year-old with storage lower urinary tract symptoms may not need a pelvic exam, but there's a lot that we can learn. And if we are not doing this exam, we can assume that nobody is doing this exam. So we can continue our neurologic evaluation with an assessment of sensation with light touch, sharp dull discrimination. We can assess the anal wink reflex, which looks at which assesses the pudendal nerve, which arises from S2 through S4. Perform a cough stress test to look for concomitant stress incontinence. Look for pelvic organ prolapse, which we know can increase overactive bladder symptoms. Assess for vulvovaginal atrophy, lichen sclerosis, and do a bimanual exam. Not only can you assess for masses, but you can look for levator ani muscle spasm or tenderness, and therefore pelvic floor dysfunction, and may help point you in that direction for etiologies of your symptoms. Patients may benefit from a pelvic floor physical therapy referral. The same for men. You can do the same neurological assessment. Look for skin lesions like BXO, meatal stenosis, look for phimosis. On your prostate exam, not only can you assess for size and for nodules, but you can do another careful palpation of the levator musculature by palpating the muscle around the prostate and doing sort of a clockwise exam to look for levator spasm or tenderness. and do a good scrotal exam. This is not going to give you necessarily any information about their lower urinary tract symptoms, but I'll tell you there's lots of patients who have come into my practice who have unrelated symptoms to their scrotal exam or scrotal pathology, and then we find a mass on exam. And so again, if we're not doing this exam, no one is, so don't skip on the pelvic. Use a voiding diary. So this is somewhat the dreaded voiding diary for people in a busy practice who sometimes feel like maybe they don't have the time to work through this, but this is your objective data. There's information, there have been studies that have shown that patients have poor numeracy or numerical literacy. They're not good at estimating. And so when it comes to storage symptoms, this is what you can get. This is going to tell you their true frequency, their functional bladder capacity. How much does their bladder hold before they get the urge to urinate? I have them record both intake and output and type of intake too, so we can assess for bladder irritants. And I have them record for at least 2 24-hour periods to avoid or to even out for any variance. It can identify 24-hour polyuria for nocturnal diuresis, which is defined as patients who make more than 1/3 of their overall urine at night, and for polydipsia, or for increased intake of bladder irritants. And so for other diagnostic testing that we have our Uroflow and our PVR assessment. I use this whenever possible to assess for bladder emptying, especially as I'm putting patients on additional treatment options. For when I'm doing a pelvic exam, I'll consider getting a catheterized PVR in females for accuracy, but also to get a good catheterized specimen. For urodynamics, it's an invasive exam, but I use this whenever my diagnosis is in question, because again, this is where we're going to get our objective data, our information about their voiding dysfunction. And so, for example, I'll use it when I have a patient with persistent storage symptoms, but they're post-BPH surgery, want to know if they're still obstructed or if it's pure detrusor overactivity. I'll get it when a patient has a concurrent neurological condition, or if a patient is already coming in with severe incontinence or severe urgency and frequency, but they also have an enlarged prostate on exam. For cystoscopy, it's not particularly useful for pure storage LUTS. So of course, if you're evaluating hematuria or you want to assess prostate anatomy for possible surgical management, then it's reasonable. But for just pure storage LUTS, cystoscopy doesn't really give much information beyond what we can get from, for example, urodynamics or other potential better diagnostic tests that we have. Okay, so once you've completed your history and your physical and whatever diagnostic testing you see fit, hopefully you have an assessment of what some of the etiologies of the patient's symptoms may be and what is most bothersome to the patient, and you can embark on a treatment pathway. So I'm going to cover the OAB management pathway and a few notes on the management of nocturia, how this relates to BPH management in men. This is by no means an exhaustive list of treatment options, and neither are these options mutually exclusive, but they're all tools in your toolbox. So we'll start with the OAB management pathway. There's the SUFU AUA OAB guidelines. And so that's what this, where this roadmap on the left here comes from, and sort of walks patients through the 3 different tiers of first line, second line, and third line management. I like to use the infographic on the right, which sort of explains that we start with some behavioral changes, and pelvic floor physical therapy is our first line, plus or minus the use of a medication, which is our second line therapies. And then moving on to our third line therapies, which is the Botox injections or neuromodulation with sacral nerve stimulation, or PTNS. So for our first line OAB therapies, we start with our fluid management. So patients should be drinking no more than 64 ounces total intake in a day. I'll have patients come in and tell me that, but they were told that they needed to drink a gallon of fluid in order to be healthy every day. And that's not right. They can drink 2 liters and be very well hydrated. If they're bothered by nocturia, we want to decrease that intake 4 hours before they're going to bed and manage their leg swelling with either some compression stockings or leg elevation or discussion with their PCP about potential diuretics. We know that constipation can worsen overactive bladder symptoms, so helping them to develop a good bowel regimen, either in conjunction with their PCP or even a GI if refractory, can really be helpful for their lower urinary tract symptoms. And control of bladder irritants. So I always tell patients to start avoiding the big 5, the carbonated beverages, caffeinated beverages, acidic foods, spicy foods, and alcohol. And then pelvic floor PT can be really helpful. They'll teach patients about urge suppression techniques, how to get to the bathroom when they do get that strong urge. Will help patients with bladder training to try to help expand their functional bladder capacity, and can really assist with patients who have some levator spasticity or some pelvic floor dysfunction that is concomitant with their symptoms. So for the second line, you'll see on the right here, there's a whole list of the different drugs that we use for our second line pharmacotherapies. We have our brand names, our generics, and the common dosages. Previously, it was that we would start with the anticholinergics and move on from there. And the nice thing about them is that at least one of them is always going to be covered by the insurance, but they have a lot of side effects: constipation, dry mouth, difficulty urinating. And in more recent years, it's come to light the significant association with dementia and cognitive impairment. And so at least in my practice and in those and in many who I know, we've moved to trying the beta-3 adrenergic agonists, which is right now just mirabegron, first. Now, the problem with that is it's not always covered. And so then we get back to the anticholinergics. But the side effect profile of mirabegron is pretty low. It can cause headaches in patients who have uncontrolled high blood pressure. It can cause an elevation in their blood pressure. It can cause some difficulty urinating, although potentially less than the anticholinergics do. And there are some significant interactions. So it can potentiate the effects of beta blockers, SSRIs, and digoxin. So if you are going to start the mirabegron and the patients are taking those other medications concurrently, I'll usually discuss it with the prescribing provider, make sure everyone's on board in case there needs to be a dose reduction of the other medications, and or if there's a significant contraindication to starting the mirabegron. Okay, so moving into the third line therapies, we'll start by talking about neuromodulation and start with posterior tibial nerve stimulation. So the posterior tibial nerve arises from the S3 nerve root, and the therapy is the insertion of an acupuncture-like needle along the posterior tibial nerve behind the medial malleolus, and it's stimulated with some electrical activity, with an electrical current, for 30 minutes, once a week for 12 weeks as an induction therapy, and then either monthly, usually it's monthly thereafter, although you can do it every 2 weeks. A nice meta-analysis in 2013 reviewed 640 treated adult patients compared to 189 controls, and noted that those in the randomized controlled trials, they reported 55 to 80% improvement in OAB symptoms. So it can be really helpful. The biggest downside is that the patient's time. They have to come into clinic in order to have this procedure done for them. There's newer data about using a home TENS unit to give this therapy transcutaneously, called TTNS. And last year in 2019, Ramirez Garcia published a randomized controlled trial comparing PTNS to TTNS, which actually demonstrated the efficacy of TTNS in reduction of daytime frequency, urgency, and incontinence. And it was the first study to demonstrate non-inferiority of TTNS to PTNS. Now, the problem with some of the studies that are out there is that the protocol for administering the therapy at home is not consistent between the trials. At our institution, we have the patients set their home TENS unit to a continuous setting on 200 pulse width, and they turn up the intensity as high as they can tolerate, and we tell them they can give themselves that therapy once a week, twice a week for 30 minutes each time, or even as much as they want to. And it's looking promising. We're still seeing how that is working in our own practice. Okay, so for sacral neuromodulation, the basic science behind why neuromodulation works is a topic in and of itself. So I'll just sort of stick to the mechanics. And for sacral neuromodulation, we place a tiny lead through the S3 foramen along the S3 nerve root, and it's attached to this battery pack, and it's continually stimulating that nerve. Now, there are currently 2 vendors who offer this therapy, Interstim and Axonics. Usually we place the device in a test phase, and that can be done in one of 2 ways. Either the percutaneous nerve evaluation, or PNE, which is an office procedure that is very low risk. Now, we place it through a spinal needle, we tape everything to the patient's back, they come in a week later, and we pull out the leads, and they go home. And it's nice because it's pretty low risk to the patient. The negative of it is that because the lead can just be easily removed in the office, it can move, and that can lead to varying efficacy over the trial period, and sometimes that's a little difficult to interpret. The alternative is doing a stage 1 in the operating room, where you'll see here there's the timed lead that's placed along the S3 nerve root in the permanent location, and then the external battery is taped to the patient. The nice thing about this is it doesn't move. It gives you a really nice trial, but the patient does need to take back to the OR either to remove the lead or to place the full implant, which is the hope for these patients. So there's pros and cons to both of those. And then for the cystoscopy with Botox, it can be done in the office or in the operating room, which is nice per patient preference and characteristics. Patients can stay on anticoagulation, especially if in the office you have the access to fulguration with a bug bee. The effects can last 6 to 12 months for most OAB patients. The average is about 9 months, although over time as patients get repeated injections, they may notice some decreased efficacy at the initial dose, or they may notice it doesn't last as long as before. The recommended dose to start with in the guidelines is 100 units. Practitioners may decide to go a little lower or a little bit higher depending on patients' prior response or other comorbidities. There is a risk of urinary retention, which is important to explain to patients. In the guidelines, they quote that at 0 to 43%, and that's more likely to occur in frail or elderly or multiparous patients. And so the recommendation is that patients are willing and able to catheterize. Now that 43% seems a little bit high, and it's likely is a little bit of it's an overestimate because the patients who are included in that, some of them were just, they had elevated PVRs but didn't require catheterization. So it's something to consider, but it's important to quote to your patients that this is a significant risk and they do have to be willing to catheterize to proceed. Okay, so that's for the OAB treatment options for your patients with storage LUTS. So just a note about Nocturia. So I explained to patients that this is a very challenging condition to treat because there are many etiologies. It can be caused by BPH, OAB, by fluid shifts, or nocturnal diuresis, which again is making more than 1/3 of urine at night. And it's important to manage expectations. It's somewhat normal for a patient over the age of 60 to wake up 1 to 2 times a night, not normal for 3 to 8 times a night. You want to use a voiding diary to understand whether this is a functional bladder capacity issue or is this a diuresis issue, and to assess any behavioral modifications that you may be able to help with in order to bring down the episodes of nocturia. For patients who do have nocturnal diuresis, treat the lower extremity edema because that can cause them to urinate more at night. Identify untreated sleep apnea. So what happens here is that for the patient who has sleep apnea that's untreated, the negative intrathoracic pressure can result in cardiac distension and release of atrial natriuretic peptide, which will then result in excretion of sodium and water leading to the diuresis. So you may have a patient who shows up who has this clear nocturnal diuresis on their voiding diary, and if they go to a sleep specialist and they're diagnosed with sleep apnea and start a CPAP, that may end up taking care of a significant amount of their trouble. I also have patients who already have sleep apnea and already have a CPAP who still have the nocturnal diuresis and maybe benefit just from some tweaks of their settings by their pulmonologist. So that's a really important one to evaluate for them. And then there's the patient who has sort of the idiopathic diuresis, potentially because of an alteration in their circadian rhythm. And for them, we can consider desmopressin. Just have to remember the risk of hyponatremia, that this is a higher risk in the elderly. For my elderly patients who, while we are working on their nocturia, always am recommending a bedside urinal, a commode, or a condom cath for males in order to just keep them safe and help decrease their falls. So even though we want to work on it so they're not getting up so much, giving them these sort of external device management options is really helpful to keep them safe. So where does BPH treatment fit into all of this? Well, if the shoe fits, start Flomax. If you have a patient who's bothered primarily by storage symptoms, who's 65-year-old and male and has an enlarged prostate in an exam, you can start Flomax. But if it's not working after a few weeks, then consider changing your course. And so that's just the thing that's sad to see, is the patient who's bothered primarily by storage symptoms, who tries and fails Flomax, and then tries and fails Proscar or Avodart, and then Cialis, and then gets a TERP, and then still comes to you because they're still bothered by their storage symptoms. So that's where we come back to treat what's bothering the patient, and if you're not improving, change the course. And if the diagnosis is in question, consider getting urodynamics. If you're worried whether you should go down or wondering whether you should go down the BPH management pathway, consider urodynamics, and it'll tell you if your patient is obstructed. And then the last thing about this is just the piece of wisdom that all of my mentors have said to me, which is the worst thing that you can do is make a dry patient wet. And what that means is that if you have a patient who's presenting particularly with severe urgency frequency, maybe they're leaking here or there, or maybe they're wet already, And that patient goes and gets a bladder outlet reduction procedure. By reducing that urethral resistance, you could potentially make the patient worse. And so for in these patients, get urodynamics, make sure that you and the patient are, sort of fully aware of what to expect if deciding to go down that BPH pathway. And a note about device management. So, while you're working through your storage symptoms, offering patients some of these devices, for the right patient, this may be really what they need. And I've had patients come in who just didn't even occur to them that they could wear a protective pad or underwear, and offering that to them at least takes some of the embarrassment off of their minds. Offering bedside urinal, bedside commode, as we talked about, offering condom catheters, which can be used just for outings at night or even all day if needed. Those do need to be fitted by nursing, and I always tell my patients that it takes about a month minimum to get used to wearing it, and sometimes they have to come back to another fitting or try a different device because different body habituses may benefit from one brand versus another. For females, there's the device called PureWick, which is this external catheter. Basically, this piece here goes between the labia, and the tubing is connected to this external vacuum device. It's pretty expensive. It's not covered by insurance most of the time. But for the right patient, particularly the bedbound patient or at nighttime, and for the patient who can afford it, sometimes this is a real lifesaver. So keeping it in the back of your mind for that right patient, it can really be helpful. So that's my chat today about storage lower urinary tract symptoms. I hope I was able to impart a little bit of wisdom or a few pearls for you. And if you'd like to ask any questions, you can go to the bottom of your screen to the Q&A section, and we can take a few.
Well, thank you very much, Rachel, for an outstanding talk. The first question relates to PTNS. Who's doing it in your office? What type of training did you receive? What is the startup cost to perform this, and how is the reimbursement?
Great questions. So in our offices, we have our LVNs and our RNs who are performing the PTNS. So there is training, and all you got to do is call the rep. Medtronic offers one, and I'm blanking on the other brand that offers the other device. But if you just call the reps for them, they will be happy to come and provide the training. I am unaware of what the startup cost might be to perform that. I apologize, but the reps can give you some more information about that. I'm not sure that there's too much of a cost. And so far, we've had really good experience with coverage. I haven't heard, for my understanding, it's certainly covered by Medicare, and I haven't had any denials by most of the private payers.
Well, thank you, Rachel, and we'll try to get additional information for you on the startup costs and who the contacts might be. Another question is, do you perform cystoscopy and Botox, or is it just your MDs who do it?
Great question. So right now I do perform them. Usually I do them, right at this point, I pretty much do them with my MD supervision. Were we to have a practice of Botox that was robust enough that we could have an extra provider like me do them, then I would be able to. But right now I'm doing them with provider supervision.
Well, while we're waiting for any additional questions, Rachel, I'll ask you, what do you find most rewarding about looking after patients with these issues?
These patients, sometimes they are a little bit afraid to come forward, particularly, and I'll say particularly in a environment like today where it seems that there are so many other things, and they wonder if their leakage or their urinary frequency is really all that important. But there are so many things we can offer for these patients to help make them better and to improve their quality of life. And when we do, they are just so very grateful. And that is what I find the most rewarding, just being able to help improve their quality of life.
The next question is, and I think some of these questions may also be giving us ideas of future Zoom symposiums, but this question is, how did you learn to interpret urodynamic studies?
So I sat for many, many, many hours with my mentors who already interpret the urodynamic studies. I learned how to do them from start to finish, and I do them still, particularly the video urodynamics. And I sat with my mentors and went through them over and over again until they felt like I was comfortable learning them. So all of this, I didn't go to a course. I know that SUNA does give a course on urodynamics in terms of how to how to perform the urodynamics, I would need someone to inform me as to whether they teach about interpretation. But for me, it was sort of an on-the-job type of thing.
And wearing my former AOA hat at the AOA meeting, typically there are some hands-on courses related to urodynamics that are open to all attendees. Question about what is the role for vaginal estrogen in women with LUTS?
Great. So I know there's like so much in this topic that we could really talk about, and I sort of grazed the surface of that. But yes, for the vaginal estrogen, if I see on an exam that I have a postmenopausal patient who has clear signs of vulvovaginal atrophy, I do talk to them about vaginal estrogen. We discuss that genitourinary syndrome of menopause can cause storage lower urinary tract symptoms, and I will recommend it as one of the treatment options.
Do you ever discuss emotional stress as a factor that can exacerbate urinary urgency?
You know, I don't discuss that enough. And now that you bring it to my attention, I will, because you are absolutely right. It is a big component, the psychological aspect, and not to diminish from the patients what they're actually feeling, but to explain to them that there is some aspect of it that that sometimes it can get better with time as the stress in their lives reduces. So yeah, absolutely. I think that's a great thing to talk about.
And thank you to two of our attendees who point out that Library has resources to help with education on administration and interpretation of urodynamic studies.
Awesome, thank you.
Well, I'd like to thank all of you for taking the time today to join. Oh, sorry, one other question. Do you or other APPs perform P&E in the office?
Yes, so I know of many APPs across the country who are performing P&Es in the office. I am also performing P&Es in the office. It's sort of dependent on the practice. They are, but they're for APPs who are interested in procedures, it's a really nice one to be able to learn, particularly if your institution or if your state does not require you to have a fluoroscopy license. Now, P&Es can be performed without fluoroscopy. I happen to find that it's nice to be able to do one with it. I find it's faster and nicer, but you don't need one in order to be able to perform the P&E.
Do you usually try overactive bladder medications before desmopressin, simply due to the side effects of hyponatremia? Or if their symptoms are just nocturia, do you start with that?
So the voiding diary, the voiding diary, the voiding diary. So if I have a patient who has a reasonable bladder capacity but has nocturnal diuresis, then all the OAB medication in the world is not going to make that patient pee less at night. But if I have a patient who has both, who has nocturnal diuresis and who has a lower bladder capacity, I'll explain to them that they have both of their options. And I'll sort of use a shared decision-making strategy with the patient. I'll explain that we might need both, you know, that we might need to decrease the amount that they make at night as well as increase their functional capacity. Now, the reason why that voiding diary is really important is because if I have a patient who comes in who has nocturia 4 times and they don't have nocturnal diuresis, I would not recommend using desmopressin for them.
What position do you have your patients in for urodynamic studies?
For women, it's always sitting unless they can't tolerate the sitting position for one reason or another, but obviously we want to make it as close to natural as possible. And for men, we just ask them, do you pee sitting or standing? And whatever they say, that's the position we do it in.
How do you treat lower extremity edema that is impacting nocturia?
I always start with leg elevation. I tell them about 5 or 6 hours before they're going to bed, try elevating their legs for 30 to 45 minutes and see if that makes a difference for them. For some it will, for some it won't, but that's somewhat of an easier pill to swallow, no pun intended, than putting on some compression stockings. But that's where I go to pretty quickly after that is if the leg elevation is not working, let's try some compression stockings. I explain to them that it might be a little uncomfortable. They might have to you know, they have to put them on first thing in the morning before they get out of bed so that the swelling is not already started. And then, you know, if the patient's really, really bothered by it and they have significant edema, I'd reach out to the PCP and just sort of ask them if they have any suggestion for potential use of diuretics or if they think anything else might help.
Well, Rachel, thank you once again for sharing your wisdom with us. I'd like to thank all the attendees for taking the time today to join us, and I hope you have a wonderful rest of your evening.
Thank you all.